All right, what do the TMA guidelines say based on this literature review that I just showed you? So in table 1, we have all of these, the literature review. And we would say, although the evidence is not there, that you should start with lower risk agents, lower risk interventions first, as I just said. There's not an evaluation of outcome, medication first or therapy first. We would still say it makes sense to get first the responders on therapy and not use higher risk agents. So you need to give people psychosocial treatments. So first you need to engage patients and parents in the initial evaluation. So they need to really be drawn in to become partners in crime, or against crime rather. Conduct a thorough initial evaluation and diagnostic workup. Look at standardized measures. And when aggression is the reason for referral, obviously you need the risk assessment, clear, are there potential harm to themselves or others. And cautiously track and reassess aggression. So I think that's the measurement-based psychiatry is becoming more and more relevant. They need to have some simple outcome measures, even if it's on a scale from 0 to 10, in order to see where does the aggression travel. If you can't use the MOAS, it would be better to use the MOAS, but have both parents, kids, and maybe teachers rate that. Obtain additional collateral information, provide psychoed for patients and families, taking some of the guilt and the blame out, making this also, in a way, a disorder, but also focusing on that we can affect it both in the bad and in the good way to make it worse or better, the aggressive behavior. Develop a treatment plan, get buy-in, and maybe give the treatment plan to them to take home, to review the treatment plan. As you know, you treat patients and families. What you discuss in the session, it's amazing what they take out of the session and then what they retain and what they bring back when you review what had we discussed, what was the plan. I mean, they're all over the place. Often families obviously have also some of the ADHD and impulsivity in their genes, and so it's very important to be concrete and give people something into their hands. And then help also to you look at community supports, and we have that in our toolkit. A couple of things in the toolkit in the tma.org. How should you assess and diagnose? So we have came up with a couple of acronyms. What's the problem? Who refers? What's the severity, the target symptoms, and what goals do we have so that everybody's aligned? So first get the Presto. And then the boulder, what are the target symptoms? Is it behavior? When do they start? When does it happen? What's the location, the duration, exacerbation, triggers, and what helps is a relief. And by doing this behavioral analysis, often the families learn quite a bit. Gee, I didn't think about it. It always happens when X happens. Yeah? So that can be very helpful as tools to go over this with parents and families. Might be hard in some offices to do for child psychiatrists with limited time, but maybe then support personnel at school and in other institutions can actually do that. And then we'll get into the medication treatment. So you want to provide and assist the family to get more child and family skills, and they should obviously play an active role in the psychosocial treatments. When that doesn't work, then think about medication. Always target the underlying disorder first. When available, obviously use evidence-based treatments. And we would say consider adding an antipsychotic. There was a big debate in the group, and we changed our wording because we had first start with a second-generation antipsychotic because the evidence is better, it's broader, there are more studies, there are less side effects, but we didn't want to be caught up in this first, second-generation antipsychotic quagmire and discussion. So we just said add an antipsychotic. And I think in child psychiatry, 95% of kids get atypicals anyway. Take into account, obviously, the latest evidence as well as safety, not only efficacy. And if severe aggression persists, following the adequate trial of a good treatment for the underlying disorder, including psychosocial treatment. So harping home again, treat the underlying disorder first. Use recommended titration schedule, deliver medication trial, adequate dose and duration, If insufficient response, first try a different antipsychotic. No switch to another class, no augmentation. Make sure that you have adequate dose and duration, that kids are not non-adherent. And if there's a partial response to initial first-line antipsychotic, you could consider augmentation. So that's also tricky. Do you switch to another dopamine blocker that might get full response in monotherapy, or would you augment because the evidence for mood stabilizers is so small and so low? But again, that was what we put here. And when they respond only partially to a first-line antipsychotic, again, reassess the diagnosis, adequacy of non-pharmacologic interventions, and then it might be appropriate to consider adding the mood stabilizer. So go through this careful evaluation first. Avoid using more than psychotropics simultaneously, so we discourage augmentation for aggression, really only if it's totally needed. And conduct side effect and metabolic assessments and clearly involve the family, again, that they know about the side effects, do the monitoring together with you. So those are the TMA guidelines, and I would suggest that we also implement that in the Florida guidelines. Yes? So in conclusion here, that we have 15 minutes to go through the recommended changes and discuss that. Aggressive behavior is common, obviously, is often complex. It's biological, cultural, and also psychological, sociological. Adequate diagnosis is obviously key. Finding out what contributes to the aggression, what is the reason for it. Try to make sure that they are safe. Treat underlying conditions, remove stressors, lowest risk intervention whenever possible. Antipsychotics have the best evidence. Clearly, stimulants should be used first in ADHD. Question is, should we even try it in non-ADHD kids? No data. And use multimodal, multi-team member approach for these conditions. So we don't have, I think for side effects, you're all very keyed into what the side effects are, and we will not go too much into all of the guidelines. There are differences in weight gain. I just want to point out that the weight gain for aripiprazole and risperidone is always stronger. Lower number needed to harm means stronger harm for autism than for schizophrenia and bipolar disorder. But my suspicion or argument has always been this is not disorder specific, this is exposure specific. So many of these kids here had never been on an antipsychotic, whereas in schizophrenia and bipolar disorder, many of them had gained weight already on psychotropic medications. These kids came just from stimulant treatment, and boom, you see much more weight gain. If they had already been for a year or two on antipsychotics like schizophrenia or bipolar patients, I doubt that we would have seen such a difference in the side effects. Well, what matters is whether they're naive. So this is the point. You see the most weight gain with aripiprazole, quetiapine, risperidone, and olanzapine when they're naive, and in switchers, you see much less weight gain because they've already been exposed beforehand. So the number needed to harm is really in naive patients 1 to 2 for 7% weight gain. For aripiprazole, not anymore at 14%, but olanzapine, quetiapine, and risperidone, yes, have also severe weight gain. And olanzapine, I think in child psychiatry, should be a last resort agent before clozapine, because there's no evidence that it has more efficacy, but the side effects are just so much more dire. After every 4th patient on olanzapine, you get one more that has 21% or more of weight gain, and that's striking. Where lurazidone will fall is unclear. We just finished a meta-analysis of the 4 most recent atypicals, paliperidone, iloperidone, asenabine, and lurazidone. This is all only based on adult data. There are no child controlled data with ilo, asenapine, or lurazidone. But the comparison against placebo, lurazidone seems to be the most weight neutral. We have to confirm that against aripiprazole and other agents. But because it could be a cohort effect. Yeah? The later you study a drug, the heavier the adults are that get into the study, so the less room for weight gain you have. And some might even lose weight if they come from olanzapine to lurazidone, the same as they lose weight when they come from placebo. So this needs to be followed up, but it's pretty consistent, even in 1-year trials, no more than 1 kilogram weight gain in adults, that is. So first and second generation antipsychotics have both contributors and risk agents in both groups, but we have lower risk agents. Neutrality in child psychiatry is quote unquote. It's really only in previously exposed patients. Even in adults who are antipsychotic naive, no antipsychotic is weight neutral. In the metabolic realm, we have more agents in the second generation cohort that have more mild to moderate adversity, and we have the least here with first, but also with second generation antipsychotics, although they are not the same. Yeah? So what we found in our satiety study was, although aripiprazole had a lot of weight gain in naive patients, 4.5 kilograms here, 5 with risperidone, 6 with quetiapine, 8.5 with olanzapine, so you need to multiply by 2.2 to get to pounds. That's in naive patients after 3 months, 19 to 20 pounds of maybe 12, 13 pounds, 15 pounds, and here we have 9 pounds. And those kids that refused treatment or had no blood level of antipsychotics, they actually didn't have any weight gain. Although they were sick, they were slanted for antipsychotic treatment. But then the olanzapine worsened everything: glucose, insulin resistance, metabolics. Whereas quetiapine did not yet destabilize glucose, but worsened all lipids, everything except HDL, not risperidone, not aripiprazole. And then for triglycerides, a pre-diabetic state, even risperidone worsened it, but not aripiprazole. So that the weight gain is not the same weight gain. There might be discordant metabolic signals. And we looked at that in the autism group, which is obviously important for our intents and purposes of aggression, because I wanted to follow up, is it really true that if you gain weight, you don't have a metabolic component, that there's this discordance? So we looked at high weight gainers that had at least 7% weight gain in blue, or half a standard deviation of BMI Z-score increase over a year, versus those that had less of that. So we look at the extremes, so to speak, and you can see that for cholesterol, even the weight gainers did not have more weight gain than the non-weight or less weight gainers. The same for HDL, the same for LDL. There's one single time point for triglycerides where the weight gainers had more triglycerides, but if you look at long-term, more than 9 months, no difference, and for glucose, no difference. So there seems to be like a protective effect. We don't know whether that's true for ziprasidone or for lurazidone. We know that when you add aripiprazole to clozapine and olanzapine, you get this blocking protective effect. You're lowering the weight, you lower triglycerides and glucose. But when you give ziprasidone to olanzapine or clozapine, you don't see that. Interestingly enough, you also don't see any weight loss or metabolic improvement when you add aripiprazole to risperidone or quetiapine. We did a randomized trial in adults where there was no difference. So it seems to be something specific for the high-risk component. Okay, so some antipsychotics have proven efficacy for aggression. At the moment, the ones approved in association with autism are aripiprazole and risperidone. Efficacy data are less robust for stimulants, but still stimulants should be given first when you have ADHD comorbidity, because they are lower risk agents and you should treat the underlying illness. Kids have more side effects, and we are very worried, obviously, about long-term considerations and shortening of life, which is why monitoring, careful treatment selection, and management of these side effects is all crucial. So the recommendations then are to replace the previous TRAE guidelines from 2003 with the TMA guidelines from 2012. I have suggested some upper dose range adjustments based on my clinical experience, not on studies, and I'm happy to be shot down on that if you feel so. I think we should potentially add a more specific monitoring guidance. I haven't put that in yet. I wanted to discuss that. What about weight and lipids and glucose monitoring? Maybe also for the other medication classes, stimulants and psychotropics, so that we make sure if clinicians use psychotropics for aggression, they graduate from psychotherapeutic interventions and social interventions, they need to do X, so that we put that also in. That's up to you, or we put a link to papers that have been stipulating what you should assess. Unusual practices, also potentially for the registry, if you can code them, would be antipsychotic prescription for ADHD without these conditions, and if they have not a stimulant on board, particularly. So if they have if you have only ADHD and nothing else and only give an antipsychotic, that would be unusual. So the clinician would have to justify, oh, sorry, I forgot to put ODD, or this patient really has conduct disorder, but I don't want to stigmatize them. You could also say ADHD without a stimulant and any other psychotropics for aggression could be something that you would flag, and most likely you can't code the psychosocial intervention, but if you have an antipsychotic and no psychosocial intervention, the clinician would have to justify, I've tried, there is nobody there, or the family doesn't go, and I need to treat quickly. Clearly, antipsychotic polypharmacy for whatever indication should be flagged, including for aggression. And either olanzapine in general, or if you can code it for those that have cardiometabolic risk factors, it should also not be given and might need prior authorization.